Okay, there it is. Okay. All right, so cold stress is easy, y'all. This is the stuff you already know pretty much. So now we're talking about it as a disease of its own, or the condition of its own, I should say. A condition of its own. I better move that. So not just that the baby's cold as a result of just being born and all that, but now it's to the point that it's causing metabolically problems. Okay? So excessive heat loss requiring non-shivering thermogenesis, or NST. Did we talk about that yet? Okay. So that's what that was. So through that brown fat, we talked about the special brown fat. So increasing the metabolism, increasing the respirations in an effort to maintain the core body temperature. So the babies that might be affected are really the small babies, mostly, right? Preterm SGA and post-term babies, those are the ones that don't have much sub-Q fat, probably, right? And then it can be any baby that's left in the cold, is in a cold situation, but those are the ones at highest risk and can be fatal. And when I say can be fatal, it's going to be probably most likely to be the ones that are, hang on, I got to get rid of the gum, sorry, y'all. I forgot I had gum in my mouth. The ones, if we're talking about babies that get abandoned outside, babies that are left, you know, outside of a church or fire station or something like that, sometimes they're abandoned. Those are the babies that usually cold stress is going to be the fatal outcome for those kids. Not just anybody, because usually we can intervene in the hospital, of course. But babies don't tolerate the environment the way we can, even in a cold house. A house with no heat, you know, the adults can wrap up and maybe survive it, but a baby might not. So really sad stories like that every now and then. Okay, so if they're cold stressed, they're going to increase their neutral thermal environment, which means they're going to increase all these other things. The oxygen, how much oxygen they need, how much glucose they use, and how much glycogen and fat, and then decrease surfactant production is also a result, yes. Remember, they start losing weight. They lose their sub-Q fat because they start losing weight after that point where the placenta stops working. They use up their energy too because the placenta is not supplying the oxygen. They get hypoxic. That's good to try to put it together though, because you need to understand it instead of just memorizing it. And with this one, the decreased surfactant production is another outcome sometimes of cold stress. And remember, babies keep on producing surfactant after they're born. You're not finished when you're born. So they need it to keep on being produced to keep those alveoli working well. All right, signs and symptoms. Some of the same ones that you've seen already. Like we know the glucose is going to drop on almost everything we talked about, isn't it? That's one of the big risk factors. So if they're cold, the respiratory rate will increase because they're working hard to just keep themselves going. Decreased skin temperature, obviously. Decreased peripheral perfusion because the heat's going to be conserved to the inner core. They're going to try to conserve their heat for their vital organs. So peripherally, they're going to be cold. Blood sugar low, and then metabolic acidosis is the result if we don't get correction. So our respirations are not our main problem. This is the first one I think we talked about where the lungs weren't one of the main problems. This is more metabolic. So intervention is to warm them slowly. You never want to warm them quickly. They're going to have apnea and possibly seizures if you warm them too fast. Monitor the skin temperature frequently. Warm the IV fluids. That's a good way to get those internal organs warmed, isn't it? Okay, and then protect from heat loss by all those ways that we've learned about. Maintain the neutral thermal environment, whatever that takes. And, of course, monitor blood sugar. Okay, so that was it for cold stress. Just those, several slides, but it's just pretty easy to understand cold stress. Just know that sometimes it is the primary reason the baby's sick. It's not something else caused them to be cold, but they just got cold for the environmental reasons, usually from being left outside or something like that. Okay? Now, hypoglycemia is the same way. It's like a disease, a condition of its own that we have to treat sometimes. So that's why this chapter is sort of talking about each part of those different symptoms you see in other diagnoses. So as hypoglycemia goes, we're always going to use 45 for our purposes. I think the hospital over there uses 46, but it doesn't matter. I won't give you a test question that gives you that close a number. It'll be something else that would be obvious. Risk factors, almost everybody. Anybody that's in stress is going to use up their glucose, right? So I don't even think I need to talk about all of those, but you just know that anybody that's got a high reason to be stressed, then that would be hypoglycemia, would be a result. The symptoms, we do need to know symptoms, especially some of the ones that we are going to see the most often. We're going to see a baby that looks lethargic, just acts really sluggish, and like they're just, they shouldn't be born lethargic. They should be vigorous and crying and all of that. And sometimes, like with our LGA babies that you think are so big and fat and they look like they'd be starving and they're sucking on everything they can get, they won't eat. They look like they would eat, but they won't. Because just because the baby looks fat doesn't mean he's going to want to eat. They're typically very poor feeders. And there's a reason for that. But the pallor, I would say the tremors and the seizure activity is another real classic one in that, some of you may have seen this, when they come into the nursery and they're jittery, they're shaking, we did a blood sugar right away. Because that's not when you want to wait for the 2 hours. We want to know if we already have a problem. We're not just screening them, we see symptoms, so we go ahead and do the blood sugar. So that seizure, tremor kind of activity is never good. So always always a blood glucose is almost our first intervention, not almost everything we do. Okay, unless we're trying to breathe for the baby, of course. So those are the biggest ones, the lethargy, the poor feeding, and the tremors and seizure activity. Okay, nursing care, we're going to screen all babies that are at risk. So if they come in with a low APGAR, they come in with anything that's abnormal, almost always the care plan calls for a glucose at least at 2 hours. So might be sooner. Early feeding is a great thing about hypoglycemia is if you feed them, it fixes itself. So if they will eat, it's great. You don't have much else to do. You just feed them. And you've fixed your problem. So even when we get like a 20 blood sugar or something, we'll just say, let's just feed him and check it again. And usually we don't have another problem after that. So unless there's something metabolically causing him to keep on dropping. So if it's breastfeeding, go right for it. As long as we're not breathing too fast or have other symptoms, then go ahead and eat. If they are too sick to eat, then we're going to start an IV and get some glucose in that way. We never give oral glucose anymore for this reason at least. The only time we give oral glucose is that sucrose for pain relief that we give during circumcisions, which I'm going to talk about at the end of this. But never give D5W. We used to have like a 5% glucose, like sugar water that you would give instead of sterile water, how we give sterile water now first. We used to give sugar water. But because of that rebound hypoglycemia, when they discovered that, they quit doing that. So it's never... You don't ever see sugar water for babies anymore. They never recommend it at home because the only reason for it was calories. And if you're going to give somebody calories at home, you want them to be good calories, not empty calories, just sugar. So there's really not a reason to give glucose water to babies. They also used to give it for constipation, by the way. Anybody still hear of that? Still, the doctors recommend it ever for constipation? Just grandma, probably. Grandma, okay. It works too, but it needs to be a baby who can handle the extra calories, who doesn't already get too many calories, because some babies already, like my Timmy, too many calories to go in here somewhere. She's got too many rolls. She does not need any glucose water, that's for sure. Oral glucose, okay, oh, I got that. Okay, so this is the only thing about this one I wanted you to see is that's where we stick the babies. A lot of you got a chance to do this, but we never stick the back of the heel because of the nerves and the blood vessels going in the back of the heel can cause problems that are long-lasting. So on either side of the heel for a heel stick. And that's just a picture of a nurse doing that. Their heels can look pretty bad after a while sometimes. Okay, y'all good on all that? That was kind of the easy stuff. Glucose and heat and all that kind of stuff. You can handle that, can't you? Okay, so hopefully you're starting to feel like you're reviewing some things. All right, hyperbilirubinemia. That's a hard word to say. I can't say that 3 times in a row. All right, so now we talked about physiologic jaundice. Now we're going to talk about the pathologic jaundice and how we compare the two. So this is good. This tells you why we have that yellow color. Yellow color of the skin sclera and mucous membranes due to deposits of yellow pigment bilirubin in the lipid or fat containing tissues. So it just sort of tends to collect there, and that's why it shows up as yellowish skin. Y'all already know all this other stuff. Immature red blood cells, 90 days of life when they should be 120. So that's one of the problems we run into. So when baby's in utero, remember, mama takes care of all this conjugation of bilirubin. They don't have to worry about a thing. Mama, the placenta filters all that. Mama's liver conjugates the bilirubin for them. So then after birth, they've got to convert their indirect bilirubin to direct bilirubin. And this just points out the reason that they run into problems, which you already know. And you can draw that diagram, right? Yeah, with your eyes closed. With your eyes closed, right, Michelle? Okay. So what can go wrong with this? It's not so much that you know every bit of it, but what can go wrong? What starts the problem is up here, is that we have too many red blood cells, right? That starts our problem. And then what? What can go wrong? Lack of albumin, because we've got to have albumin. And then there can be some other weird stuff in here, but then the next thing really is down here. No bacteria, needs bacteria. So what would make the baby not have bacteria? Sterile gut. What else? Not eating. So he's NPO for some reason. Y'all are so smart. It's so good. Y'all, you had to study this. This is good. So they're NPO for some reason, and they didn't get to eat. Or what's the other reason? What if they are eating, but they still have not enough bacteria? Why would that be? Antibiotics. That's another good reason, though. Not the bacteria, but if they don't have bowel movements, if they're constipated, then that stool's going to sit there. Stool's going to sit there and going to be reabsorbed, turn into unconjugated again. Yes, it's a weird little diagram, but it kind of does get the point across, doesn't it? Okay, so y'all got this. So if it's physiologic, it's always after the first 24 hours. And if it's pathologic, it is often before the 24 hours. Not always, but it's never normal to have it before 24 hours. And most often it's because of hemolytic disease of the newborn. And that's that ABO incompatibility or either the RH thing. That's usually the reason. I mean, there can be other reasons. There could be liver disease. Baby could have some kind of abnormal bile duct. There can be weird things. But the most common reasons are going to have to do with that. So this is a list of the contributing causes. Increased amounts of bili delivered to the liver. So what would, every baby has too much, like 65% hematocrit. But what would cause you to have even more? What? Late cord clamping. So they got that transfusion from the placenta. I can't hear you, Adeline. Disease. One of those diseases we were just talking about. We were talking about a lot of them. Oh, hemolytic disease. Oh, sorry, yeah. So it's, and then also we have issues with, why would we have more red blood cells than we normally do? Hypoxia, good. Good, bruising or cephalhematoma. Cephalhematoma is a perfect example because they've got all that blood. They've got to do something with all those red blood cells. So if they have a lot of bruising, they could just have like a nuchal cord and have a real facial bruising from that. Because when they have a nuchal cord, it kind of like chokes them and they get all these petechiae popping out everywhere. And that's bruising. So they've got to get rid of all those red blood cells somewhere. Any baby that has a lot of bruises, we got a problem with bilirubins usually. So those are all good things. Y'all got this. So increased amounts of bili delivered to the liver, defective hepatic uptake, defective conjugation. That would be like that that would be kind of either some sort of metabolic problem, or one of those receptors in there is not present that needs to be, that kind of thing. Defect in the biliary excretion, that means constipation probably, or whatever reason, not making bilirubin into the stool or the urine. Increased reabsorption of biliary from the intestines, which is the constipation issue again. So to prevent it, maintain a stable temperature, because we don't want baby stressed, right? Monitor the stools. We want to make sure that if they're not having stools, that we do something about it. If they're, we're talking about the first newborn period. And biggest thing we can do to help them is make them eat. If they will eat and poop and pee, then usually this all works itself out. But if you start getting really high bilirubins, you really have to do more to encourage the feedings. We start feeding them every 3 hours instead of every 4, and we try to make sure they get it. And sometimes to the point where mom has to pump her milk to measure it and then feed it. That's rare. They don't usually do that, but if they're really worried about this baby, they might have to. Okay, and then breastfeeding jaundice, we talked about it a little bit, but you need to know that, the peak is different, much different, the second or third week, mostly due to dehydration. This baby that's the main reason, is that baby's kind of dehydrated, so there's a more concentrated hematocrit, and they tend to have higher bilirubins, yeah. Sometimes related to the increased free fatty acid in some mother's milk, but that's the more rare kind, right? That's breast milk jaundice. Breastfeeding jaundice is the one that's more dehydration, okay? And breast milk jaundice is rare. Related to increased absorption of billy across the intestinal wall, sending the billy back to the liver. And the exact cause is not always known. Still very mysterious kind of causes. Okay, what day of life is physiologic jaundice? When does it start to show? Okay, after 24 hours, but typically when? Second or third day? Okay, so how common is it? Very common, okay. I can't remember the exact number, something like, I was going to say 60% or something. What was it? What did y'all say? There you go, okay. What causes the yellow color of the skin or the sclera? Positive bilirubin where? In the fatty tissue, that's right. Okay, and what is considered a high level of bilirubin? Unlucky 13, there you go. And remember, that's a very generalized statement, but it's kind of something to go by. And how does the nurse assess for jaundice? Bony prominence. Bony prominence. Head, chest, nose, chin. So while it's blanched, it looks yellow. Okay. Pathologic jaundice appears before 24 hours. The total billy exceeds the 95th percentile on a nomogram, and that means basically the doctor pulls up a graph on the computer now. They use them on their phones or whatever, because you either have to do that or you have to do this equation to figure it out, because it has to do with how many hours old is this baby and how much does he weigh and all that. It's very, it's not just a matter of what the number is. So we're upset about a 5 or a 6 bilirubin on day 1. So it varies. 13 is just for physiologic jaundice. And so anyway, we're going to pull that up, and if it exceeds the 95th percentile, then we're going to intervene. And it lasts more than 2 weeks if it's pathologic too. Doesn't just gradually fade like it should with physiologic. And kernicterus is the reason that we worry about bilirubins. This is why all the fuss over bilirubins, because we don't want kernicterus. It means that the level has gotten high enough to cross the blood-brain barrier, and now we have central nervous system damage. So that's what we're trying to avoid. So acute bilirubin encephalopathy is what it's called, caused by high levels of indirect bili not bound to albumin crossing the blood-brain barrier. Very bad thing. It can happen at different levels, but around the 20 area is where we get really concerned. If not treated, indirect bili can deposit in the brain, causing severe and permanent central nervous system damage, because we can't heal the central nervous system very well, can we? Possible outcomes are death, cerebral palsy, mental restrictions, hearing loss, speech delays, hyperactivity, learning difficulties. Everything to do with brain damage, basically, whatever area is damaged. And these are certainly not seen very much anymore since we are right on top of jaundice, but you see people who don't get prenatal care. You also see people who go home with a jaundiced baby and never go back to the pediatrician. They don't go for checkups. They don't get a follow-up, and that baby's getting more and more yellow. So these are the ones you're now going to see it in more, and in other countries as well, but we're on top of it in general. So it can occur mostly because of the RH issue or ABO incompatibility, which is what these next slides are about. You really don't need to worry about that slide. Let's just skip to this one because it kind of tells the whole story. If it's ABO incompatibility, then it just means the mom is type O and the baby's something else. So they can be O positive. They usually are O positive. But baby's either A or B or AB. And so therefore, when the blood mixes, if the blood mixes, then mama's going to build up antibodies against the baby's blood, right? Because her blood doesn't recognize A or B. Starts building up antibodies, and if those antibodies transfer back to the baby, then those antibodies will attack the baby's red blood cells. And it's a really bad thing. So most of the time, we're just going to see some small effect from it if we stay on top of it. So causes significant jaundice, usually treatable, and rarely results in hydrops fetalis, which is I'm going to show you in a minute. But that would be the worst outcome. That's much more likely to happen in the RH issues. Mom is RH negative, baby's RH positive, and RhoGAM kind of fixed this problem in general. This is actually a diagram of the RH thing, and I know y'all have this memorized already anyway, don't you? You know about the RH and that issue, right? Okay, so I'm going to skip over this, but that's a good review of the mama's antibodies attacking the next baby. Not that baby, but the next one. But the ABO compatibility can happen with the same baby. This is a picture of those red blood cells being attacked by the antibodies and destroyed, which you can see would be a real big problem. So the treatment, if it's caused by ABO incompatibility, is phototherapy. So as soon as we see that bilirubin start going up, we're going to start phototherapy. And then if that doesn't do it on its own, the worst result or the end treatment would be an exchange transfusion, which we don't usually have to do. We don't see them very often at all, but if it's a severe case, they will. And you do see it in the RH thing. But exchange transfusion just means that you're withdrawing some of the baby's blood and infusing some donor blood at the same time, or you draw out a certain amount of the baby's blood and infuse a certain amount of the other. So eventually you're getting a better concentration of blood that doesn't have all those antibodies in it attacking the red blood cells. Everybody get that? Yep. Okay. That's exchange transfusion. So it doesn't mean we're going to take all the baby's blood out. We can't do that, can we? So we've got to do it more slowly. So you're just trying to change the concentration over time. So you're drawing out a certain amount, infuse a certain amount, draw out a certain amount, infuse a certain amount, and eventually the mix should be more of the donor blood and less of that damaged blood or blood that has the antibodies in it. Erythroblastosis fetalis is caused by RH incompatibility. Usually that's going to be the most common one. And it is a hemolytic disease of the newborn. I'll show you a picture of it in a minute. But the RH negative mom, I'm not going to read that again, that's the same thing we just said, can be prevented with the administration of RhoGAM. Since somebody smart invented RhoGAM, it has not been a problem in America, except with no prenatal care. Or if mom was not totally honest and didn't talk about an abortion that she had, a miscarriage she had, didn't tell the doctor, or there's just not a good history there to work with. So that can still happen, but you're mostly going to hear about it in other countries or no prenatal care. But because moms will think, I've already had a baby, I don't need prenatal care. I know I've got vitamins, I'll take my vitamins, And if they got that RhoGAM issue that they needed, that could be a real problem. Okay, hydrops fetalis is the worst outcome. of this incompatibility of the blood. And it's the most severe form of erythroblastosis fetalis. I'm going to show you a picture of it and then I'll come back to this slide, but that is how bad it is. So these babies seldom survive. They are very, very sick. And this explains why. So destroys the red blood cells, anemia, multi-organ system failure, that's what's happening, and cardiomegaly and severe cardiac decline, hepatosplenomegaly, so all of that's enlarged, and massive edema, which you saw in that baby's pleural effusion into the pleural cavity, pericardial sac, and peritoneal cavity. So these babies might die in utero and be, one of those babies that's either a stillborn or a fetal demise. So it could be either, but like I said, we don't see it very often. I knew somebody who was probably born around 1950s or something, because this person was older than me, and had scars, femoral scars on both sides. I suspect this is what he was born with, because as a child I saw his femoral scars, and his mother just knew he had some problem with her blood and his blood mixing. So now I'm thinking that must be what happened. And he was one of the lucky ones that they cannulated quickly and did exchange transfusions and were able to save him. But that was probably an RH thing, because that's what they had to do. They had to do a quick cut down and try to exchange the blood. And you can imagine in 1950 that probably wasn't a real easy thing to do or a common thing to do. But so they can survive, but it's have to much easier to prevent. So that's our worst outcome. That's what we don't want to have happen. And then of course the connectorus is the reason that the other thing that we want to prevent. I've got to go back pretty far for the connectorus, but that's the main one we're trying to prevent, because that's the one we're going to see more commonly if they don't treat the bilirubin. And this is a problem when you have early discharges. And back when we were discharging babies at 24 hours, they went through something with the insurance companies were only wanting moms to stay 24 hours and they had to go home. Anybody remember that? Really? They made you go home that early?
That's what I was going with. They told me I had to go home, but our baby had to stay.
Oh, okay.
Yes, but it was a doctor. That's the.
No, his partner, Williamson died.
Williamson died, and it was a doctor. The lady goes, I got to have my baby, and went to the I'll be my room.
Yeah.
The doctor discharged you.
Oh.
And your baby, you have to come back tomorrow and get your baby. My daughter baby got to stay there so many days. I said, well, you need to tell the doctor to come here because I'm not going.
He does not know who he's dealing with.
Yeah. He said, but at MSC, that's how they do it.
Okay.
Yeah.
C-section.
Yeah, she said.
Now, that's just ridiculous. Yeah. I think it. Yeah, if your baby's sick, that's one thing, but if not. But yeah, that's the problem, is when they did that, the insurance companies got into a lot of trouble for it, because there were babies who were jaundiced, weren't jaundiced at discharge, but they got jaundiced. And then nobody picked up on it, and not every mother is going to get their baby to the doctor quick enough. They're probably going to wait at least 2 weeks, and that's too long if your bilirubin's rising every day. So you can see why that'd be a big problem. And then there was actually some protests and some legislation that had to happen to force that system to change somewhat. So it's interesting to me. I guess they could still make mamas go home, but not babies. Yeah, they can definitely discharge the mother and not the baby, but I don't know how soon it's okay to discharge. There's complications the mama's going to have too, in just 24 hours that you'd be concerned about. But anyway, let me go back to where I was. I hope we're not going to ever see any more hydrops fetalis babies, but I guess there'll always be somebody. Can't figure out where to go to put my foot up a little bit. I'll try to sit back here on this thing instead of standing. Okay, so phototherapy. You got to know all about phototherapy for this test, okay? I'm telling you now. Warning, fair warning. So basically it's black lights. It's fluorescent lights or black lights that we want to expose the skin to. So it decreases billy in the skin by facilitating biliary excretion of unconjugated billy. So it's almost like doing the job of the liver, the billy light. It's amazing. I don't know who figured it out, but whoever it was a very smart person. So it changes bilirubin from fat soluble to water soluble, just being exposed to these lights. So billy is converted to photobilirubin, which can bind with albumin. You don't have to go through anything, travel to the liver, and be eliminated in stool or urine. So basically it expedites the process. Still has to go through the liver, but it's already converted. So it's really speeds up the whole process. So because we want it to be water soluble, and it changes it to water soluble, and therefore we can get it through the stool and the urine, right? Okay, so the billy lights we use a photometer to measure the strength of the bulb. So you have to do that like every shift, and you have to record the numbers so that if you have any weak bulbs, you get them changed. You have to always know that it's working correctly. And then you have a certain number of inches from the baby that the lights are distanced. If they're the lamps types of overhang kind of phototherapy, old-fashioned type, then you have to have it a certain number of inches from the baby. And then they could have billy blanket or billy mattress. Billy mattress would be more common in the hospital, but not the billy blanket. Something you could use at home easier. Okay, let's look in your book for this part. Did I bring my book? Yeah, it is. So there's a table in there that's about it's basically like a little care plan kind of thing. Let's see if I can. Is it the wrong page number on there? 642. Okay, yeah, this is a great little chart, a great little way to learn it, to talk about how we're going to take care of the baby. So let's highlight parts of this. Down on the first column there under where it says procedure and then rationale number 2, remove all the baby's clothing except the diaper. So we're going to keep the genitals covered. And there's not real good evidence what happens with the genitals if we don't cover them, but it's kind of just one of those things where they're giving the baby the benefit of the doubt. They don't really know what the result would be, but always they try to cover a female or male. But the diaper should be normal size for that baby, not cover half their body like that baby up there in that picture. If the diaper covers most of the skin, we're sort of defeating the purpose. And then number 3 there says apply eye coverings. So you have eye patches, which is a billy mask, always when you have the lights on. And again, we don't know how much that affects the eyes, but they assume it could hurt the eyes. And number 4, you're going to use an open crib or isolette, either one, and place the phototherapy a certain distance from the baby and reposition the baby every 2 hours. That's if you're not using a billy mattress. Because if you only have light up above, then you want to rotate the baby kind of like a rotisserie thing. You've got to get them done on both sides. So, but if you have a billy mattress, you don't have to do that as much. So let's see, it kind of explains that under there. And then you see the picture of the mask. Then number 5 is vital signs every 4 hours, at least every 4 hours. 7 is cluster care activities. And some of you did get to do some of this. Remember when we had to feed the baby every 3 hours. Usually we want to feed them more frequently than most babies. And we cluster the care. And I would tell y'all, make sure that when you wake that baby up to do vital signs that you also have the bottle ready, that you have your thermometer right there. You don't want to unwrap the baby, turn the lights off, take the billy mask off, and then go looking for your thermometer and this and that, okay? You want to have everything ready. A lot of you did get to do this, or a few of you did. So clustered care is important because the longer you have that light off, the less we're working on that baby's bilirubin. Discontinue phototherapy and remove the eye patches at least every 2 to 3 hours. And this drives me crazy. I'll see nurses take the baby out to feed and never take the mask off during the whole feeding. They've got the lights off and holding the baby to feed them, but don't even take the mask off. But please give the baby a break. It's got to be awful to have patches on your eyes all the time and you have them forced closed. They can't open their eyes. Okay, and then number 12 on the next page, signs of perinatal excoriation. That's because we're making him pee and poop a lot. And he's going to get excoriated, so you got to really take care of his skin. And also because these babies are really fussy. They're not happy under these lights, so they tend to move around a lot. They get their knees excoriated if they're on their tummy and their elbows if they're on their back. And then it mentions in 13 that you always turn the lights off to draw the blood, because they get a lot of blood draws for the phototherapy, for the bilirubin, and it will change the numbers if they keep the lights on. 15 down there says avoid ointments or anything on the skin, and that's because it could cause them to be burned under those lights. Okay, and then up on the next page, 643, the Billy mattress is shown in that picture. It's a terrible picture, but it kind of gives you an idea. Billy mattress is just literally the lights are coming from below instead of above. So usually babies who have that also have the lights over them. Okay, and then under 17, it talks about the Billy blanket. And remember, we can mostly see that at home. It's not as effective as the others, but it is wonderful in that you can pick the baby up. They also don't need eye patches. That's an important point, because for the mothers at home to be able to hold their babies, you know how we have to leave them under that light and make them miserable for 3 hours and they can't be picked up, they can't be clothed. That wouldn't work too well at home. Mothers aren't going to tolerate having their baby cry like that and be miserable. Plus, the older the baby gets, the less he's going to tolerate it. So this blanket is a great solution. When this was discovered, it's a really great thing. It's still plugged into a cable, so you've got to sit in a certain place to hold the baby, but still at least there's a blanket around the baby and you can hold him and cuddle him. All right? But he doesn't have to have eye patches. That's a really great thing. Okay, 647 goes through some of the stuff we've already talked about, but if you wanted to read more about the blanket or anything, but I think we covered the main stuff. That table kind of gives you a good overview. Let's see what was next. Okay, so that was it on phototherapy and pathologic jaundice. Y'all good with that? Okay. Moving right along. Polycythemia. This is another one of those things that's just a symptom of a lot of other things. But we're going to talk about it as it within itself. So greater than 65 for your hematocrit. And these are all the things that would cause it. I think we both basically talked about them already. Well, we didn't talk about twin-to-twin transfusion, but y'all know about that. Chromosomal abnormalities would just be some diseases would cause this, so you don't really need to worry about that one. You don't really need to worry about any of those except the ones we already talked about. Diabetic mom, asphyxia, stress, placental transfusion, post-maturity, but I have several on here you don't need to know. Okay. Symptoms. Remember, this baby's got really thick blood. This is the problem. So what would go with that is what you need to be thinking about, you know, logically, what would happen if your blood's too thick? It doesn't flow very well, does it? It doesn't pump very well. The heart has trouble pumping it. So makes the baby kind of a sluggish baby. So the viscosity of the blood is thick. Causes impaired perfusion of the capillaries, makes the skin very ruddy. So this is that really pink, beautiful baby that you think looks so healthy and pink. When somebody says, oh, your baby is so pink, then you might want to go, wonder what's going on here. When they say your baby has a lovely complexion, you think about jaundice. When they say the baby's so lovely and pink, you think about polycythemia. You can't think normal anymore. You're a nurse. You got to think different. So, okay, and then tachypnea and congestive heart failure are due to increased volume, so they're going to breathe faster because they're dealing with all that extra fluid. And congestive heart failure would make sense in that case. Respiratory distress because they are dealing with that, and hyperbilirubinemia. Too many red blood cells. Poor tissue perfusion, decreased peripheral pulses because it just doesn't flow very well. Decreased urine because even the kidneys are, sluggish. Seizures, jitteriness, and irritability due to decreased brain perfusion. So again, that makes sense. Make sure it makes sense to you and you won't have to memorize things so much. Decreased tone and lethargy. They're just sluggish babies. They got sluggish blood and they feel yucky. They feel lethargic. And poor feeding. These are the ones that you think are big and fat and pink and they should eat, but they don't usually eat very well. The treatment, if it's severe, is to do a partial exchange transfusion. Don't usually have to. Most babies can deal with it on their own. And if they're jaundiced, then that helps that they get the phototherapy too. That just explains what an exchange transfusion is. In this case, instead of replacing it with donor blood, you're replacing it with something that's going to thin out the blood some, and that would be frozen plasma or albumin or isotonic saline. And usually there's no treatment. Most of the time they can be dealt with on their own. Okay? All right, y'all got polycythemia? You ready for some more? Okay, let's keep going. The group B strep is not too hard to handle because that's the only infection we're going to talk about. There's a lot of other ones listed in your book. There's a table of herpes and gonorrhea and all that. But all of our symptoms that I'm most worried about, I'm put on this slide for you. So when we got a baby who's septic, this is the early signs we start seeing, and then we start seeing some of these other signs, and then we have septic shock on the right. So the initial signs would just start, all those sick signs. The baby doesn't seem like he's doing too well. He's breathing too fast, all that respiratory distress kind of symptoms. And then also down here, he's lethargic and he has poor feeding. That is really very classic for infection. We start worrying. The baby doesn't act right, doesn't ever want to eat. He just doesn't ever seem to be active, doesn't seem to be vigorous ever. Then we start thinking something's not right. And then the temperature instability is also classic because I remember how many times I've told y'all, let's go ahead and warm the baby back up again. He's a little bit cold, let's warm him up. Well, that's okay a few times, but after that, you can't do it anymore. You can do it anymore, but you can't excuse it anymore. You have to find a reason why he can't stay warm, and it's often infection. That's almost always going to be the case. So if they keep on having to be warmed up, the next thing they'll do is blood cultures and CBC. Okay, so after we see these main initial signs, hypoglycemia goes with almost everything. But this is a baby that instability here, pallor is classic too. They just start looking pale and peaked, kind of just they look sick. Those are the main ones I care about in the middle there. And then of course if it's full-blown septic shock, you're going to have all the vital signs will be affected. Baby's got weak pulses, mottled skin, stops putting out urine, and gets metabolic acidosis, which is really bad. And also, low blood pressure is never a good thing in anybody, but this is always a result of, always going to happen if you have septic shock. So, that's everything about infection all in one slide, okay? And I think your book takes several pages of that, so I'm really interested in what you just kind of recognizing it. And I think the treatments are obvious. Y'all know how to treat infection. You get a blood culture before you start your antibiotics, right? And then you start your antibiotics until you get your blood culture, narrow down your antibiotics, all that. You know all that. So I don't think we need to go into all that. Okay, let's take a break then, and before we start this part, because I think we just have a couple of topics left. I mean, we're doing pretty well, better than I thought we would. All right, do 10 minutes. I was worried we may not finish, but I think we might actually finish. Oh, did it come back on? What did I just do? Yeah, okay. Just shrunk. Okay, so our next topic is pain assessment, and it is not in the book, but there's some really important things I think you should know about newborn pain in particular. And I have a lot more slides here than you need, so I'm going to tell you to eliminate a few of them, okay? Actually, the first two after this. We're going to eliminate that one and that one. It's good information, but you don't need to know it for the test, okay? And actually the next one too. So the first one we really need to talk about is this one, okay? So facts about pain. I'll read it off here. In infants and children, unrelieved pain in infants can permanently change their nervous system and may prime them for having chronic pain. And what this means is that some of the research is showing that babies who experienced a lot of pain for legitimate reasons seem to react differently to pain later in life, and maybe has something to do with how their nervous system is maturing and growing at the time. So, these things are all hard to prove and hard to study and all of that, because you don't know what caused what sometimes. But they do seem to think that babies who had a good reason to be in a lot of pain have a different kind of reaction. And it's not a good thing. It's not like you get used to pain and you learn to deal with it better. If pain wasn't managed early in infancy, it's much worse for the baby later, or the child later, or the adult later, in terms of their tolerance to pain. So the idea that some people treat pain in children as, well, they're not going to remember it anyway, or maybe their nerve pathways aren't complete, so they don't feel pain the same way. That was some of the rationale that were given to not give pain medication to babies for years and years, and which makes absolutely no sense to me. But I'm a baby advocate. But even if you're not, it kind of makes sense if it's a human being and you're doing something painful. It probably hurts them too, but they would actually think that because they didn't have a mature nervous system, they couldn't sense the pain, so they did not treat them. So I'm going to skip that one too. So possible physiologic signs. This slide you need to know well, okay? This is about what you're going to see when you see pain in a baby. What's that baby going to look like? 'Cause, sometimes people say babies don't communicate, and I tell you they do communicate. You just have to know how to read their signals. And this is part of that. If they're in pain, these are the kinds of things you're going to see. The vital signs will definitely be affected, increased, but shallow respirations, because they're in pain. If that kind of makes sense, doesn't it? If somebody's in pain, they kind of just sort of guard a little bit and breathe less deep but faster. Shrill cry, in that it's a different kind of cry, because when you're a baby nurse of any kind, even for pediatrics, you hear cries differently. You can hear a lot of babies cry, and you can tell which one is the cry that you don't ignore, because usually they do have a very different kind of cry. This is the one time you will see them sweating sometimes. When else did we talk about sweating, by the way, as review? Who else sweats? What did the babies sweat? Hyperthermia caused by what? By us, yeah. We did something to cause them to be hyperthermic. And then what's the other one? Red flag for what? Along with sneezing and yawning and... Baby that's always sneezing, always got a stuffy nose. Drug use. I didn't hear you. Sorry, I didn't hear it. When you're all talking at the same time, I can't always hear you. But anyway, yeah, it's drug withdrawal. So those are the only times you're going to see sweating. So you're not often going to see sweating in babies, but with real extreme pain, you can see it. Decreased oxygen saturation, because they really are fighting this problem, so everything else is affected. And then if they measure EEG changes, you would see that too. And that's how they do. A lot of times when they're studying pain and doing research, they'll study for circumcision. babies who are having circumcisions, and chest tubes are the other thing. And adults, they study chest tube pain too sometimes when they're trying to just study pain. So that tells you how painful it is. And with circumcisions, it's just an accessible way to study normal newborns. It's only male newborns, but it's still not babies that are sick for any reason. Okay, possible signs of pain in the neonate. So this is behaviorally. That you just kind of can tell by the way they're whimpering and crying, just being kind of puny acting, that you can just a kind of pitiful sort of sound. And if they do have a sleep-wake cycle yet, which you won't see in the newborn nursery probably, but it would start to change their sleep-wake cycles later. I think that's all we need in that one. And then this one is basically kind of the things you would expect. If a baby's in pain, they're going to try to withdraw from what's hurting them. So that makes sense. That's just a reflex for them to get away from the pain. And then becoming rigid. That's those babies that are rigid and crying, and fists are, they have their fists all tight, and they're just looking stiff and mad and crying. Okay, and then this is about the actual shape of the actual specifics of the face. And this next picture is what is a kind of a classic ones that they use. Isn't that awful? But that's kind of the classic measurements that they use. So I'm going to go backwards in a minute. But they're actually looking for a different kind of facial expressions than you would see in just normal crying. So this is explaining it, this previous slide. What was that? Okay. So eyes tightly closed or opened, mouth open and squarish, so they're really got a different shape to the mouth, furrowing or bulging of the brow, quivering of the chin, and deepened nasolabial folds. So that's what that all looks like. So they put some of that into a measurable scale in trying to determine when babies are in pain. And this is the name of some of those. You don't need to know the names of them, but what I want you to know is kind of more what they're looking for, what kinds of common things they have that they're looking for. See, like this one talks about the face, the legs, activity, the cry, and consolability. So then it's going to grade them on a 0 to 2 scale. And we do use these when we have babies that seem to be in pain for whatever reason, maybe a clavicle issue or hip dislocation, things like that. This next one is very popular, and some of the same things. Crying or irritability is measured, and behavioral state, just kind of talking about whether they're restless or whatever. Facial expression, and then extremities or tone, and vital signs. So this one's more specific, and it would give us a good rating. It goes negative numbers and positive numbers, but mainly I just want you to kind of know that there's a way to do that. Just like, what's the famous one for the peds that you use? Remember that one? Cases, that's right. So it's the same thing, it's just done with, it's the same idea. You're trying to objectify the pain, put a number on it so that you can then see if it changes with your interventions, if it gets better or worse. Don't have to memorize those scales by any means, I just wanted you to be aware. I think it's interesting that American Academy of Pediatrics even had to ever make a statement about pain, but they did. And they said, has recommended the administration of local and systemic drugs for anesthesia and analgesia to neonates undergoing surgical procedures. I always go, well, duh, because they're going to have surgery and not do anesthesia or any kind of anything, but that was what was happening and why this had to happen. Circumcisions was one of the classic ones, but there was more involved surgeries than that, like eye surgeries and things like that they were not using any analgesia. And even after the surgery, not giving the baby pain medicine. Does that just blow you away? We didn't need a study, it didn't seem like, to tell us that. Let's help these poor babies. States that any decision to withhold these drugs from infants is not to be based solely on the infant's age or perceived degree of cortical maturity, perceived degree, meaning the doctor's perception of the degree of cortical maturity, but rather on the same criteria used for older patients. It's a shame it was necessary, but I'm sure glad they did it. because now they are held to that. That's the standard of care, and they have to treat babies for pain. This is just about the sucrose for pain thing, and about the study and all that, but it basically they're giving glucose, concentrated glucose water, either on a pacifier or with a syringe, right before a circumcision, and sometimes during the circumcision, and it is amazingly effective. And we're not talking about just effective in making them happy to have something sweet, but it changes the signals of pain to the brain in some way, where they've measured EEGs. It actually works. So it's pretty incredible that you can give glucose, concentrated glucose, to babies and make them more comfortable. But it really does have some research to back it up that's been well established. So I think it's wonderful. We did have a student one time that when he graduated, he came up with a circumcision care kit, and he was trying to market it. He actually had it patented and was going to market it and everything. He came and showed it to me. It was already, you had to peel the package open. He'd already had to the point of having all the packaging done and everything. It was so cool. But it had this in it, and it had the Vaseline and stuff like that in it, some soothing kind of things. And it was kind of this little kit he was hoping to market to hospitals to give to the parents to take home with them. I never saw it on the market, but I don't know what happened. I would love to know that he was a millionaire now, but I don't think it actually did happen, but it was really cool because that was the idea, and that's when this was just getting started, and they didn't commonly have it in the hospital, but it was okay to give it. This is the golden rule my golden rule is what is painful to an adult is painful to an infant and a child unless proven otherwise. We're going to give them the benefit of the doubt. And that's the end. He's just so cute. I meant to put some pictures of our family in here, but things got in my way. I didn't get my new pictures in here. But y'all will see them on Facebook anyway. So, anything we need to review from our other chapter? I know today's you probably feel pretty good about, but what about anything, you gotta know everything about preemies and post-maturity, SGA, LGA, infant of diabetic mom, because that was a long chapter. Preemies was really long. Preemie was really long too, so I'll give you a lot of slides, but I think that's usually a good thing. And some of them were just a bunch of pictures, but I try to put things in a nutshell, but when I told you to refer to the book, I try to tell you, when you needed to do that. So, because the book gives you an awful lot of detail that you don't necessarily need, so some of it you do, but only if we talked about it. Okay?
How many questions?
60. It doesn't have 60 yet, but it will have 60. Because it needs to have at least 60, and I think that's Miss Murphy's kind of rules, so we'll keep it at 60. I want you all to do well, I really do, especially those of you who really need to do well. So I hope I've given you all the tools to do that with, and I'm really glad you're not having to study 5 chapters instead of 2 this year, so because you can imagine what position that puts people in at this point if they're pushing their grades are really close and you got that huge amount. But usually it does work out, but I think when you start to get these almost help you with the other ones because they all kind of overlap and reinforce one another, so hopefully. But call me or let me know if you have a problem or a question because I want to see everybody do well, okay? All righty. Let me let her know. Thank you for what?
Our last lecture.
Oh, yeah, y'all need to, well, you got to change this. Yeah, change this up here. Stop it.